Yes.
Okay. All right. So let's give it a start here. So, okay. Hi, everybody. This is a webinar that we're going to talk about for why does pelvic pain hurt? My name is Dr Greenstein. I'm a urologist with Advanced Urology, and I have two very good people with me today, two very good guests, Adina Leifer and Blair Green. They are some of my go-to people when it comes to pelvic pain disorders. So let me just introduce them. So Adina Leifer is from Able Physical Therapy and Blair Green is from Catalyst Physical Therapy, both in the Sandy Springs, Dunwoody area. So a little bit about me, because as my wife says, it's all about me. So I'm a urologist. I've been in practice since 2003. I finished medical school in 1997. So I'm in my 18th year of practice at the time of videoing this. I specialize in all kinds of urologic care, men's health, female health, urologic cancers, kidney stones. But one of the things that I got into over a decade ago was treating pelvic pain disorders. And that's why I want to put this webinar together. Adina is one of the pelvic floor physical therapists with extensive training in orthopedics, manual therapy, women's health, men's health, pelvic floor dysfunction. She did her doctorate at Turrell College up in New York, moved to Atlanta a while ago, used to be in Norwalk, Connecticut, specializes in all different things related to the pelvic floor dysfunction, and has the ability to say that she did specialized training at the Herman and Wallace Institute, which is well known for their pelvic floor physical therapy. And Blair is from Duke, so Blue Devils. I'm a Blue Hen, so kind of close. And she did her master's degree of physical therapy from Hahnemann University. And it turns out that Blair and I were in the same city at the same time, but we never even knew each other. She then came to Atlanta, began her career as a physical therapist, earned her doctorate of physical therapy later on, and then revamped her style of physical therapy by focusing mostly on pelvic floor dysfunction and pelvic floor issues as her career continued. And so what's the agenda today? The agenda is one, let's review some anatomy. Let's review some symptoms. We're going to talk about conditions. We're going to discuss the importance of physical therapy. As I tell many of my patients, they're the magicians that make this aspect of treating people, they make it work. I'm just the guy who says, this is what you need. And then we're going to talk about case reviews. We're going to go over some specific cases that have occurred. So what is pelvic pain? We got a nice little definition here. Unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Occurrence of chronic pelvic pain when there is no proven infection, which is very important, or the other obvious local pathology that may account for the pain. It is often associated with negative cognitive, behavioral, sexual, or emotional consequences, as well as with symptoms suggestive of lower urinary tract, sexual, bowel, or gynecologic dysfunction. I'm reading that for like the 100th time, but it's amazing how important that is to understand this, because I'm sure Adina and Blair can vouch for the hundreds of patients they've seen that were probably told that this is an infection, or this is a uterus problem, or this is ovarian, or this is a testicle problem, or a prostate problem, when it's not. And that's a very important thing to understand. Okay, let's get the mouse to work here. There we go. Okay, so here's a little bit of anatomy lesson for women. There's a diagram on the left that describes the nerves, specifically the perineal nerve, which comes from the pudendal nerve. There's a lot of discussions out there about the work and the treatment of pudendal nerves when it comes to pelvic floor dysfunction, because it is the main branch of nerves that head down to the genitourinary system. And genitourinary system just means the genitalia and the urinary system. On the right side, it talks about the superficial and the deep muscles. I can always let Adina and Blair discuss this, and we're going to go over this in a second. For men, it's almost the same thing, except There's no clitoris, there's a penis, but the muscles are exactly the same. There are a little bit of a difference because you have, like, for example, a bulbospongiosa muscle, and that's not really developed in a female. But on the right side, you have the nerves. The nerves are almost exactly the same. And specifically the pudendal nerve, which is the branch that comes off of the sacrum, and that's what feeds the pelvic floor. In men, you have a dorsal nerve of the penis. In women, you have a dorsal nerve of the clitoris. This is, I think, one of my favorite slides that talks about the brain-pelvis connection, because what I learned years ago is that people who have pain have a different brain on their MRI, not in the sense of shape, not in the sense of the way it looks, but the way it functions. And there have been some very unique studies where they took a person who doesn't have pain and they MRI'd them, and they were able to show the activity of what's called neurotransmitters, as written on the left. And then they took a person who was having pain and they did the same MRI, and the MRIs look completely different. And that's why when we see people like this, it's a full body experience. It's not just your pelvic muscles, your prostate, your ovaries, your uterus. It is treating the brain, it is treating the mind, it is treating the emotions, because it's all connected. Adina, Blair, anything to comment so far?
No, I think you're hitting all the points.
I'm getting it all. All right. So what are typical symptoms for a woman? Pain in the pelvis, pain with intercourse, urgency, cramping, burning with urination, difficulty emptying their bladder. I've had women describe an itch, or there's butterflies, there's constipation. It feels like something is inside. So no offense to my urgent care doctors or the ER or some other physicians that are out there, sounds like a UTI, right? But it's not. So what are some typical symptoms for a man? Pain in the pelvis, pain with erections or ejaculation. If a man says to me it hurts when they ejaculate, that's muscle, 100%. That's not infectious. Urgency, cramping, burning with urination, difficulty emptying their bladder, also itchiness, constipation, feels like something is inside, scrotal and testicular pain. And a lot of people will describe as if they're sitting on something, almost like there's a golf ball when they sit down, or a tennis ball. And if you look at this sounds like prostatitis. Let's give this person antibiotics, but that's what we don't like to do. So what are conditions that are associated with pelvic pain in women? The big one is, I don't know. I'm sorry, but we just don't know. We know you hurt, but we don't know why it is. But then there's common things: interstitial cystitis, endometriosis, pelvic floor dysfunctions, trigger points, recurrent UTIs, pudendal neuralgia, and childbirth. And what about for men? Same thing, idiopathic. We just don't know. But men can still get interstitial cystitis. There's pelvic floor dysfunction, trigger points, prostatitis, both infectious and non-infectious, and, like we mentioned, pudendal neuralgia. So how do we diagnose a pelvic pain condition? Hey, Adina, can you just describe, like, when a person comes to your office, what are you looking, like, how are you diagnosing them?
Yeah, so in physical therapy, we do a internal vaginal for women, rectal examination for men, to assess what their pelvic floor muscle function is and what the movement of the muscles are. And we can assess if there's spasm there or if there are trigger points, and that helps us guide, where the pain is, and then how we can really treat it. So that's mainly what we do. We hear patients' symptoms and then look at the actual muscle and tissue to see what's been going on.
So in the urology office, because a lot of these people are going to come to us either off the internet or from their family doctors or gynecologists, we do a history and physical. History and physical is key. For women, I'm going to do something called a Q-tip test. A Q-tip test is where I literally take a Q-tip and I touch the vulva. The vulva is just the inner part of the vagina. And I'm going to see if any of that hurts them or burns, because a Q-tip should be soft. But if it burns, that tells me something. Like Adina said, I'm going to look for trigger points and tender points, but I'm also going to do basic urology things. We're going to check a urinalysis. We're going to have you urinate into this funnel called a flow study. We check to make sure you're emptying your bladder. That's a bladder scan post-void residual. Sometimes I'll do an EMG that looks for nerve patterns, but I'm going to tell you that if you can do a good history and physical, then you are going to be able to diagnose this because the patient is going to tell you the answer. They're going to say it in words that are going to tell you what's happening. In other words, like for men, it hurts when I ejaculate. That's muscular. Women, it hurts when I have sex. That's muscular, could be bladder, could be vaginal. It hurts when I hold in my bladder. That's IC until interstitial cystitis until proven otherwise. So what tests are performed to diagnose a pelvic floor condition? Like I mentioned, we'll do an EMG that checks nerves. We do a lot of ultrasounds in urology. So we'll ultrasound the pelvis, we'll ultrasound the bladder, we'll ultrasound the kidneys to make sure you're not having a kidney stone. We'll ultrasound testicles for men. If we think, we'll do a CT scan. In select cases, I'll do a very specific MRI of the nerves. That's called an MRN, or a magnetic resonance neurogram. And that's looking specifically for nerve entrapments in select individuals. We do a lot of cystoscopy. Cystoscopy is where I take a camera and I look inside the bladder. In other words, make sure there's nothing in there. Make sure there's not a stone, a growth, infection, interstitial cystitis, whatever it may be. Sometimes we have to refer people to gastroenterology to perform a colonoscopy. Sometimes they need to go to their gynecologist for either hysteroscopy or pelvic ultrasounds by a gynecologist. All right, why is pelvic floor physical therapy so important? Blair, what do you think?
So I think with a lot of pelvic pain disorders, really just kind of treating together sort of in this multidisciplinary approach is super important. So working with the doctors who are typically running tests and putting patients on medication. But a lot of what we do is we help the patients learn how to function better. So especially when we're dealing with muscle dysfunction, it's important that we can help these patients learn how to relax and do what's called down training their muscles. So often these muscles are typically tight or in spasm, or the nervous system is telling them they have to protect. And so a lot of what we do is teaching the muscles how to relax. We can do that through manual therapy. So we do a lot of hands-on work. As Adina described before, when we're doing our examination, it's typically intravaginal or intrarectal in the case of men. And we can also use similar techniques to help stretch the muscles, help reduce the trigger points, help improve the circulation and the tightness there, which ultimately is going to help reduce the pain. And then once the patient starts feeling better, we can teach them a lot of different techniques they can use to manage their pain, such as breathing or mindfulness or specific stretches and exercises that are going to help them move better and feel better. And then finally, if there are issues such as urgency or incontinence or constipation, we can help teach patients how to use their bowel and bladder a little bit more efficiently, whether it's positioning or timing or just retraining how the muscles work. We can start to restore some of that function as well.
Excellent. Thank you so much. For anybody who's watching this, I would go reverse on your little YouTube thing and go watch it again. All right. So of course it's about me. So what can a urologist do? Well, if I think I'm going to perform cystoscopy to make sure a person doesn't have interstitial cystitis, if I think it's important, I'm going to start medications. So I'm a big fan of treating things locally. I don't like to do a lot of pills with this unless I feel it's absolutely necessary. So for example, men and women with pelvic pain, I'll have them use what's called a Valium baclofen ketoprofen suppository. So this is a medication made specifically for an individual. You can't get it from CVS or Walgreens. It's made at a compounding pharmacy, and it's a combo medicine. So Valium's a sedative, baclofen's a muscle relaxant, ketoprofen is just like ibuprofen or Motrin, so it's an anti-inflammatory. And they would use this suppository at night, sometimes during the day, but mostly at night, to soak into the muscles, soak into the local nerves, and get things to just calm down while they're sleeping. Other medications are like gabapentin gels, ketamine gels. There's another medicine out there called nifedipine. But sometimes we do have to use medications like duloxetine and amitriptyline. Now, these are antidepressants. And if we go back to that video, or not the video, the slide that talks about the brain, that's where these medications come in to help with the neurotransmitters realign so that they get into appropriate state. And that helps take down some of the nervous system while we're working on the local structures. I can do prostate ultrasounds. I'll do nerve blocks if I need to, perform Botox injections into the muscles in very unique cases. And that's kind of what we think about when patients are in our office. So let's talk about the multimodality approach. I've kind of been hinting to this the whole time. So you need a urologist, you need your primary care doctor. Sometimes, a lot of times, we need a gynecologist on board. Psychology and psychiatry are very important. If I have someone who's in my office and they're miserable, I'm going to make sure that they get in touch with a psychologist and or psychiatrist. It's important to treat the brain at the same time. Sometimes we have to get the GI doctor on board. Of course, we need our pelvic floor physical therapy team. And sometimes in unique cases, we'll get pain management or a physical medicine and rehabilitation, also known as a physiatrist, on board. Adina, Blair, anything to add at this point?
No, I think good.
We're good? Okay, so let's talk about case number 1. So 24-year-old female is diagnosed with recurrent UTI. She's been to urgent care 6 times in the last 9 months. A urine test shows occasional blood in the urine. Only 1 culture was ordered and was negative. She will receive antibiotics and feel better. She feels that symptoms start after intercourse, and intercourse can be painful. She comes to my office. She does a urine test, showed small blood in the urine. We did a kidney ultrasound to make sure that there's no stones, and that was negative. I do a physical exam. The Q-tip test is negative, but on pelvic exam, she has a left-sided tenderness. Blair, let's say this person comes directly to you with this exact story. And then let's pretend the office is a primary care doctor's office, in other words, or a gynecology office because they did the Q-tip test and things like that. So this person's coming to you. What are you going to do?
So just looking at her symptoms and looking at the tests that were done, I've already got a pretty big inclination that she's like a classic pelvic floor dysfunction, overactive pelvic floor muscle case. Mostly, I think the negative Q-tip test, so we're ruling out any sort of vulvar pathology or anything on the surface that might be involved, and seeing that the pain is on the left side of her pelvis, so it's just one side, and she describes her symptoms starting after intercourse and during intercourse. Those to me are 2 big clues that it's probably a muscular problem. So what I would probably do, where I would start with her, would be an internal vaginal exam to really be able to identify which regions of the muscles are sort of the big offenders and where we need to work. And then a lot of what I would do from there would probably revolve around which muscles are tender, doing a lot of manual stretching, down training like we talked about, deep breathing techniques to help calm down her nervous system, possibly giving her something like a vaginal dilator to help maintain tissue length, or help just retrain that pain-free intercourse so that she can get back to doing things like that.
So can you talk about the dilators at all? Like, what's the difference between a dilator and something like a TheraWand, like something where someone can do self-manipulation?
Sure. So that's something that she could also use. So typically with the TheraWand, what we're doing is we're teaching the patients how to do their own trigger point release and myofascial work. So the TheraWand, it's kind of like S-shaped somewhat. And so it has like a handle and a part that you can insert either into the vagina or into the rectum. And we can show the patients where their trigger points are and teach them how to release those trigger points themselves or stretch the muscles using the wand.
Nice.
The dilators, I like to use them more as like a desensitization tool. So typically for people who have had pain, especially with intercourse or vaginal penetration for a while, they're not going to feel really comfortable inserting anything in the vagina. So often these are graded from like super, super small, like even smaller than my pinky, to maybe the size of like a normal penis that would typically penetrate into the vagina. So what I'll do is I'll teach the woman how to insert them and usually leave them there for a while, do some deep breathing technique, and calm down the nervous system so that she learns that that penetration is no longer threatening to her nervous system. And then we can kind of work our way through from the smaller sizes up to the big.
Excellent. Blair, I think I lost you for a second there. There you go. Oh, okay, she's back. So from a oh, that's what it is. It's my internet. Lovely. So from a urologic perspective, I can tell you this patient has interstitial cystitis until proven otherwise. And definitely interstitial cystitis is related with muscle dysfunction. That's why this is all put together. So when I have her in the office, you know, I would examine her, talk to her, and then I would tell her, we talk about diet. We talk about a medicine called Urabel, because Urabel has a combo medicine with hyoscine, which is a smooth muscle relaxant to help relax the bladder and the bowel. It has a little bit of we'll call it an astringent in it called methenamine that can be used to kind of like clean up the urine to prevent bacteria from getting in there just while we're working this up. And then it coats the bladder to numb it out a little bit. The fun part is that it turns the pee blue. So I tell people not to pee in the pool. Otherwise people will know it's you. And then I tell them I need to do cystoscopy on them because I need to make sure that they do or do not have interstitial cystitis. And that's where things like a hydrodistension comes in. Sometimes I do some old school urology called urethral dilations. Sometimes I do also something called a cauterization of the trigone, because the idea is that if there's irritation in the bladder, we want to get rid of it. On top of doing this, I then get her to physical therapy. All right. Anything to add on this one? We're good? Okay.
Yeah. I mean, I would just add also that you want to just make sure that they're emptying their bladder with that.
Yes. So that would be, you know, that would be part of the urologic workup, you know, to make sure that their post-void residuals are low. Because one of the things we see in people who guard, you know, I'm going to use that term. I know you and Blair use something a little different. They clinch down on their pelvic muscles and they don't empty all the way, and it causes them to hold on to their urine, and people who don't empty their bladder well get these infections or get infectious like symptoms. We'll call it like that. All right, case number 2. 52-year-old female is newly dating. She's having episodes of painful intercourse. She will also have episodes of vaginal burning without a discharge. She had 2 children born by C-section 25 and 22 years ago. She wakes up at night to urinate, but no other symptoms, no other urinary symptoms. In the office, her urine test was normal. Once again, she has pain on the left side of the vulva with a Q-tip test. She has pain on the left side of her pelvis. All right, so I already picked on Blair, even though it says Blair here. Adina, this person looks you up on the internet. And she says, oh my God, I got to go see Adina. She makes an appointment. What are you going to do for her?
Yes. So the first thing that kind of jumps out is that she's 52 years old. So the first thing that we're thinking is this is either premenopausal, kind of the beginning of some menopausal changes. So I would also do an internal examination, see what's going on with her pelvic floor muscles, what her movement is, kind of go over how menopause and estrogen can really affect the changes of your pelvic floor muscles, and how, you know, she can kind of work with the exercises within physical therapy to create blood flow, which thereby brings strength. And also I would have her see either her urologist or a gynecologist to speak about possible estrogen cream to help build up that hormone. And then of course, bladder retraining, even though she's only waking once at night. She's a little bit young to getting up at night, to kind of increase her water intake during the day and really retrain her bladder function.
So from the urologic perspective, so with the positive Q-tip test, I would think that she's got some element of a vulvodynia. In other words, the inner part of the vagina just hurts. And so if it's really that bad and it's disrupting her sexual life, I would probably put her on either gabapentin cream or ketamine cream or something like that she can use to help calm down the nervous system in that area, so she can, have a successful sex life. With the pain on the left side, I would hope that the ketamine or gabapentin would help for the deeper pelvic structures, but sometimes this may be a candidate for the Valium baclofen suppository. And of course, if there's postmenopausal changes, certainly I would think about a topical estrogen, which goes into the vagina. So there's estrase, there's Premarin, there's compounded estrogen, and then there's also something called Vagifem, which is very good for helping rejuvenating the vaginal tissue with very low side effects. All right, let's go to the next one. Case number 3 before our internet connection seems to go. All right, 28-year-old male is having pain after ejaculation. He went to his PCP, who diagnosed him with prostatitis. He was given antibiotics and feels better. The symptoms returned, so he went to a urologist, who again diagnosed him with prostatitis and gave him 1 month of antibiotics. This time he did not improve. Now he has pain in his perineum, his left testicle. He's also straining when he needs to urinate. In the office, urine test was normal. He empties his bladder well, and his ultrasounds are all normal. He has a completely normal exam. Adina, you're back on. What would this guy, once again, this is a guy who looks you up on the internet. She says, I gotta go to Adina. What do I do?
Yes. So the first thing we also want to notice is that he was given antibiotics and he felt better. And that happens because the antibiotics have some element of a steroid in there, which kind of calms the pelvic floor muscles down. So this really is a very classic case of pelvic pain in men. And they kind of think they have other things going on, and then they shop around and figure it out, and then finally realize that it's just their pelvic floor muscles that are causing a lot of their pain. So very similarly, I would assess rectally, what his pelvic floor muscle function was. And again, work on down training, make sure he is followed by a urologist, again, for that Valium baclofen compound, which is so important to have to kind of calm those muscles down. And I feel like it even helps with physical therapy. When they're on that medication, it really allows for the relaxation of the muscles so that we can do our job better, and that we can really help the patient kind of retrain their muscles and get them, as we've said before, to down train, to kind of calm their muscles down. And that really is the key. So again, it would be really a focus on stretching the pelvic floor. And we teach them, this is where a TheraWand might come in for men. And then also working with them on breathing and exercises to kind of strengthen the muscles around the area so they don't overuse their pelvic floor. The same thing would follow through that kind of question, like how's your bladder function? But that would be the main thing, would be really to work on relaxing his pelvic floor muscles and making sure he's getting the right compound with Valium.
Yeah, so these are always the tough ones, because these are the people who come in and I don't want to sound rude, but this is the patient that says, Google told me I have prostatitis. WebMD says I have prostatitis. And I'm like, well, sorry, I don't think you have prostatitis. I'm more than happy to work you up and do all the things, but this is muscle guy and we need to fix your muscles. And like you said, the Valium baclofen in these cases, I find to be highly successful. All right, let's go to the next one. Oh, I put a little diagram in there. So this once again just shows the diagram of the muscles that we used before for male pelvic floor patients. All right, last one. 6-year-old male fell off a ladder while cleaning his gutters and landed on his tush. He did not break anything, but a few weeks later, he developed severe constipation, rectal pain, pain in the penis, and he can no longer get an erection. He does his own internet research. He goes right to pelvic floor physical therapy. Blair, what are your thoughts?
So a couple things that kind of stick out to me. One is that he fell off a ladder, landed on his behind, and says he didn't break anything. One thing I'm probably concerned about there is his tailbone. It is rare to fracture your tailbone, but that can happen with falls. So for an x-ray and rule that out just so we know what we're dealing with there. But certainly even without a fracture in the tailbone, there could be a lot of spasm around that posterior pelvic floor area. Something else to consider, especially given he's having pain in the penis and he can no longer get an erection, is does he have some sort of pudendal neuralgia or so nerve damage, maybe as a result of this fall or as a result of maybe some of the muscle spasm that might be affecting the nerve a little bit and creating some of these sensations. So I would want to get him a medical exam and just rule out those things first. But then certainly with falls, with any really kind of trauma in the pelvic region, there's always going to be associated, for the most part, pelvic floor muscle dysfunction. So just like everything Adina described with the other patient, I'm probably going to do a lot of similar things to see what's going on there. And in terms of the constipation, teaching him how to do certain things like using a squatty potty is actually really good in these situations. It takes a lot of pressure off the pelvic floor muscles so that they can have better bowel movements, help those muscles relax. If there is any kind of nerve pain involved there, also maybe teaching him some nerve gliding, or which are specific stretches that work specifically the nerve itself to kind of help calm the nerve down as well. So in addition to all the other sort of manual things, muscle relaxation, stretching, etc., those are some things I would probably add specific to this patient.
Yeah, so, definitely you want to make sure there's not an anatomical thing. If this person is not responding right away to medicines or physical therapy, that's where I would get an MRN to see if there is some kind of neuritis or nerve entrapment. Or sometimes we pick up on things that someone had before their fall and now it's aggravated after the fall. And so he would do well with pelvic floor physical therapy. He would do well with the Valium baclofen suppositories. Lot of self-help for something like this because he launched up real quickly with his pain, as opposed to some people where there's just a very slow process that just builds. He took off like that, and which means we got to get him down real quickly. Thank you so much. All right, so that's pretty much all for our pelvic pain little webinar here. I want to thank you so much. I put Adina and Blair's contact information right here. Hopefully you guys can see that. And if there's any questions, please don't be afraid to give us a buzz. Adina, Blair, anything to add in a concluding remarks or anything?
No, just thank you for having us. I think this is great. And I think it's really important for physical therapists and urologists and physicians to work together for the patient's best interest.
Yeah, I would probably say the same. I think, I know at least for my patients, probably one of the greatest assets I have is having doctors that we can work with, because we do see a lot of patients kind of how we describe that find us on the internet and maybe haven't had a medical exam. So knowing that it really does need to be a multidisciplinary approach is the best thing we can do.
Yeah, the multidisciplinary approach is key. I can tell you in the last few days, just working, I've been on contact with a psychologist, a PM&R doctor, a gynecologist, an orthopedic, like all to help out our pelvic floor patients. And of course, contacting you, reaching out to our physical therapists and being able to say, this is what I think is going on. This is what's happening. That way there's no guessing games and everyone's working for the common goal for the patient. So I wanted to thank Adina and Blair for being on this webinar today. I think it's super important just for education and also so that patients can help themselves, get access to doctors that can help out with these conditions. So I wanted to thank everyone and have a good night.
Thank you. Good night.